Hello everyone. Today we will be discussing the guideline for prevention, diagnosis and treatment of infertility which has been released by World Health Organization 2025. So this is the front page of the guideline. I have included the salient points, what the changes are there in the new guideline, and so kindly be attentive. Firstly, we will be discussing about the epidemiology and global burden of infertility. As we can see here in this chart, very beautifully, they have made the chart about the epidemiology. 1 in 6 people of reproductive age experience infertility at some stage in their lives. And if we divide the factors which are responsible for infertility, we can see here in the bar chart, the female factors are responsible for around 31% and the male factors in roughly around 20%, both male and female 26%, and no causes found in 10.8%. So now we can see here this does not make up a total of 100%. Why? Because while they were conducting this study in 8500 couples, the 10% they conceived while the study was going on. So this is how roughly they have divided, and we can see here the male factors, they contribute wholly or in part in 45% of the infertility cases. Okay, so this is a bigger chunk which the male plays the part. And the estimated lifetime prevalence of infertility is the 17.5%, and estimated period prevalence of infertility is 12.6%. So this is what the epidemiology of the infertility is. Here we can see the specific diagnosis of infertility. They have divided as female differently and male separately. So no cause could be demonstrated in 33% of the cases, while the most common is the bilateral tubal occlusion, which is seen in 17.7% of the cases, followed by pelvic adhesions, which is seen in 14.8% of the patients. Then in male, the no cause could be demonstrated in 46% of the cases, while varicocele is seen in 13% of the patients, primary testicular failure in 12% of the patient. The same thing is here in the diagrammatic form, the specific diagnosis of infertility, which is making it easy to understand. As we can see here, up to 40% cases, no demonstrable cause, and most common cause is the bilateral tubal occlusion. In male, you can see here the no demonstrable cause in almost around 40 to 45% of the cases, and varicoceles in you can see here 11 to 12% of the cases. Now coming on to approach to evaluation and management of infertility. Firstly, we will be discussing the diagnosis of infertility. This is the tabular form in which I will be making it easier for you to understand how it is. Firstly, we can see whenever a couple is approaching, first and foremost thing is to take the history. And the female in couple with infertility history along with physical examination, while male we will be discussing later on. In female, if everything is normal, the history and physical examination, if it is normal, then what we will be doing is we will be confirming the ovulation and we will confirm the tubal patency. So these are the two foremost tests which we have to do, provided the history and physical examination are normal. And according to the new guidelines, what is the method which is used to confirm ovulation? It is the mid-luteal serum progesterone, which is to be done 7 days before the expected date of menstruation. And if it is normal, then if both are normal, the tubal patency and ovulation, then the unexplained infertility is labeled. What is the method to do tubal patency? Either HSG or HyCoSy. So this is new. HyCoSy is equivalent to HSG, both can be used. HSG has the problems with radiation exposure, while HyCoSy has no radiation exposure. So if any problem is there during evaluation of this, the same problem will be tackled, while if both are normal, along with the normal semen analysis, it will be unexplained infertility. Now coming on to if there is some problem in the history or in physical examination. Suppose in the history there is problem with there is history of a sexually transmitted infection, or there is a history of pelvic surgery, then suspected tubal disease is there, and we have to investigate the tubal patency either with HSG or hycosi. If there is suspected uterine cavity disorder, which can be with the history of abnormal uterine bleeding, or while doing the bimanual examination there is some pelvic mass, then the uterine cavity has to be evaluated. How to evaluate the uterine cavity? So the recent guidelines say SIS is the preferable method, but 3D is always preferable if it is available. But if it is not available, it is the saline infusion sonography, which is the second preferable next to 3D ultrasound. If any cause is found, then the uterine cavity abnormality might be the reason for infertility. If there is in history there is absent or irregular periods, then there is a suspected ovulatory dysfunction, and then there is the battery of hormonal analysis which we have to do, which will include the FSH, LH, the estradiol, testosterone, and depending on the history, the TSH and prolactin, and accordingly the management. If there is nothing is identified, then the optional investigations are to assess the ovarian reserve, which previously the guidelines were saying AMH or AFC, but now the present guideline is saying AMH, AFC or FSH along with estradiol. So all three are equally weighted. Now coming on to diagnosis of infertility due to ovulatory dysfunction, as I told in the previous slide, what is used is initially what is used for ovulatory dysfunction diagnosis, it is the mid-luteal serum progesterone, and in case it is abnormal, a repeat measurement is suggested to minimize the risk of an inaccurate diagnosis of anovulation. What is the plasma progesterone level that is considered? That is, it should be less than 1 nanogram per ml, and plasma hydroxyprogesterone typically less than 0.2 nanogram per ml. We always have some problem of having this nanogram per ml, picogram per ml like this. So how we can remember is P for progesterone, NM. These all come together. So D is distant. So NMLNOP, like that we can remember. These all alphabets come together. N, M and P. So that's how we can remember. It is not in nanogram per deciliter. It is in nanogram per ml. By these alphabets you can remember it. Coming on to assessment of ovarian reserves. So what can be used is AFC, AMH or day 2 or day 3 FSH. But this FSH we have to do along with the estradiol. Diagnosis of infertility due to tubal disease. Either HSG or hycosi, that is the hysterosalpingo-contrast sonography, we can use to diagnose the tubal patency. Diagnosis of infertility due to uterine cavity disorder. So SIS rather than 3-dimensional ultrasound, provided 3D ultrasound is not available. But whenever 3D ultrasound is readily available, that is the most preferred option for diagnosis of uterine cavity disorder. Prevalence of congenital uterine anomalies, it is around 4% in fertile women, but in women with infertility it is around 3.5 to 8%, while in women with recurrent pregnancy loss it is around 13%. Okay, so the highest prevalence of congenital uterine anomalies is in the women with recurrent pregnancy loss. This is the diagnostic algorithm for assessment of uterine cavity. The same things are there, just in the algorithm form which I explained. Whenever a woman is coming with the medical history and physical examination which are suggestive of uterine cavity abnormality, if there are no constraints, if resources are available, always go for 3D ultrasound. But if resources are not available, go for saline infusion sonography. In case saline infusion sonography has detected the problem, then further treatment has to be done. In case 3D ultrasound has detected the normal cavity, that it means mostly it will be a normal cavity only. But if some polyp or septum or anything is diagnosed, treatment is accordingly. In case the saline infusion sonography as well as 3D ultrasound are not available, both are not available, then we have to resort to 2D ultrasound or HSG. So the first line is 3D ultrasound, second line is saline infusion sonography, the third line is either HSG or 2D ultrasound. And depending on the results, the further management will be done. Although even if the positive result have been obtained on HSG or 2D ultrasound or negative reports have been obtained, they are not very sure, because there are a lot of false negative rates. Diagnosis of infertility due to male factors. We can see here how to approach a male. Firstly, we have to take the thorough medical, reproductive and sexual history, then the physical examination and a basic WHO semen analysis, which we are following the 6th manual. So depending on that, further management will be done. These are the history points which we have to take in a patient with male factor infertility, and the physical examination, starting from the head to toe examination, the overall, the virilization status, gynecomastia, the body mass index, any scars, inguinal or genital regions to rule out any inguinal surgeries, any hernial sites, how the penile structure is for any hypospadias, epispadias, phimosis, curvature, because any hypospadias, epispadias, these all problems can create the problem in depositing the semen in the posterior fornix, which is usually the place where the semen is deposited. And we have to palpate the testes to see the location, whether they are high up or in the inguinal canal or in the scrotum, the size, the consistency, which should be firm, not soft, not hard, any pain, any nodule or tenderness, which can be suggestive of any infections. Ductal structures, presence of vas deferens, whether it is absent or sign of any obstruction or inflammation or any beaded appearance, spermatic cord or scrotum for any varicocele, hydrocele or cysts. All these things we have to check and take proper history. Recommendation for semen analysis. So WHO suggests repeating the semen analysis after minimum of 11 weeks. Why this 11 weeks has taken? It is not arbitrary, because it is seen that the one cycle of the spermatogenesis take around 72 plus minus 2 days. So that comes out to be somewhere the 10 weeks plus 6 days. So that's why the 11 weeks have been taken for the repeat semen analysis. But in case the semen analysis is normal, there is no need to repeat it. We can see here it takes around 74 days, which is equivalent to 4.5 cycle of seminiferous epithelium. Diagnosis of unexplained infertility. Failure to achieve pregnancy after 12 months of regular unprotected sexual intercourse in presence of normal physical examination and medical history in both male and female. When ovulation has been confirmed, the tubes are patent in female partner. Semen parameters are within WHO reference range in male partner. Treatment of infertility. So WHO suggests using letrozole over clomiphene citrate or metformin in case of anovulation due to polycystic ovarian syndrome. Using letrozole alone rather than metformin is suggested. But sometimes when the letrozole use is not permitted, some countries it is used as off-label, that time the clomiphene has to be used. But if we are using clomiphene, it is preferable to use with metformin. So clomiphene citrate with metformin rather than clomiphene citrate alone or metformin alone is suggested. WHO suggests using gonadotropins over laparoscopic ovarian drilling. For females with infertility due to ovulatory dysfunction caused by PCOS who have been unsuccessful with pharmacological therapy such as letrozole, clomiphene with metformin or with gonadotropin, the third line management is IVF rather than keep on expecting the patient to conceive on their own. Then if the ovulatory dysfunction is because of hyperprolactinemia, the drug suggestive is cabergoline over bromocriptine. So the same thing in the tabular form. The first line is the letrozole. Second line, letrozole, or if letrozole is not available, then clomiphene with metformin. Second line is gonadotropins instead of LOD, which is an alternative only. And third line is IVF. Treatment of infertility due to ovulatory dysfunction caused by hyperprolactinemia. Normal prolactin levels in women are 25 microgram per liter. And in men, they are 20 microgram per liter. Although hyperprolactinemia is diagnosed in less than 1% in an unselected general population, it is reported to occur in 5 to 17% of women with secondary amenorrhea and 6% of those with infertility. Bromocriptine is the primary dopamine agonist against which newer ergot derivatives are typically compared. Some patients may not tolerate bromocriptine at therapeutic doses. Why? Because of the nausea and vomiting which bromocriptine at therapeutic doses causes. So that's why the cabergoline, it is a newer ergot derivative which has a longer half-life. We all know we have to give it only twice a week. So, and sometimes even once a week is also sufficient. Because of the long half-life, it is taken only once or twice weekly. So that leads to less of the side effects and thus the therapeutic compliance. So the recommendation is in favor of cabergoline. Treatment of infertility due to tubal diseases. For female aged less than 35 with mild to moderate tubal disease, there is a Rutherford classification which checks the tubal anatomy. It is dependent on the tubal anatomy, the patency and the potency of the tubes. And it suggests there are grades in it 1, 2, 3, 4. And if it is 1 to 2 and woman age is less than 35, then the surgery is what WHO suggests rather than going for IVF. And after surgery, minimum period to wait is 1 year before going for IVF. This recommendation does not apply to females who had previous tubal sterilization. So specifically, this note has been made. For women less than 35 with Rutherford grade 3, WHO suggests in vitro fertilization then surgery. Any woman more than 35 with any tubal disease, whether 1, 2, 3, WHO suggests in vitro fertilization rather than surgery. So more than 35, WHO suggests IVF only. Less than 35, if it is 1 and 2, then surgery. If it is Rutherford 3, then IVF is preferred. And whenever there is hydrosalpinx, salpingectomy and tubular occlusion are always preferred. But in case where the salpingectomy and tubular occlusions are not visible, maybe because of the frozen pelvis or a lot of tubal adhesions, when the laparoscopic surgeries are not visible, then transvaginal aspiration may be offered. Treatment of infertility due to uterine cavity disorder. This is very important. For female with infertility and uterine septum who have no history of recurrent pregnancy loss, WHO suggests that hysteroscopic septal resection, that is septoplasty, not be performed. Just mere presence of infertility, septoplasty should not be done. Treatment of infertility due to male factors. Role of antioxidants. Guideline development group did not make a recommendation for or against the use of antioxidant supplements because there is not much sufficient data. Treatment of varicocele is something which they have emphasized for male with infertility and clinical varicocele. there are two options, surgical or radiological treatments over the expected management. So they are not talking about the males who are not infertile. Just simply without infertility, there is no need for varicocele if they are asymptomatic. But if there is infertility and the semen parameters, they are not in WHO 6th range and a clinical varicocele is present, in those cases either surgical or radiological treatment is indicated. This does not apply to the men who are undergoing treatment with assisted reproductive technology. Varicocele treatment is suggested for men with infertility intending to conceive if they have clinical varicocele, first point. Secondly, semen parameters that are outside WHO reference range. If both of these criteria are met, then only the varicocelectomy is indicated. What are the surgical treatments which are offered? Surgical treatment involve varicocelectomy conducted via retroperitoneal or conventional inguinal open techniques, microsurgical inguinal or subinguinal approaches, or laparoscopic repairs. We will come further in further slides, we will come to it, like which surgical treatment we have to offer. Then radiological treatment, they involve either varicocele embolization or sclerotherapy. The goal of both surgical and radiological treatment is to stop reflux in the internal spermatic vein. So what is the recommendation? Microscopic surgery is always preferred in all the surgical, out of all the surgical procedures. And which microscopic surgery? Subinguinal microsurgery is a common surgical varicocelectomy procedure which is the most commonly done. Again, this is not applicable to the men who are undergoing ART. Microscopic varicocelectomy is performed using a subinguinal approach which involves making 2 to 3 cm transverse incision centered over the external inguinal ring to approach the spermatic cord with the aid of an operating microscope, after which spermatic veins are ligated while preserving the testicular arteries and lymphatics. Why preservation of testicular arteries and lymphatics is important? Because the most common complication after varicocelectomy is hydrocele formation because of the inadvertent damage to the lymphatics. So if the microscope is used, only the spermatic veins are ligated. So there are other complications associated with varicocelectomy: varicocele persistence, recurrence, and injury to surrounding structure. Postoperative hydrocele formation is a frequent complication of varicocelectomy resulting from disruption of lymphatic vessels. So if we use microsurgical approach, these complications can be reduced. If we are using non-microscopic surgical treatment of varicocele, WHO suggests either inguinal or retroperitoneal surgical procedures. Again, they are not applicable to men who are undergoing ART. Inguinal varicocelectomy involves an incision over the inguinal canal starting at the external inguinal ring and extending 3 to 4 cm laterally parallel to the inguinal ligament, which allows identification of spermatic cord and exposure of enlarged pampiniform veins for ligation. The conventional non-magnified open varicocelectomy is also known as Ivanisevich technique. Retroperitoneal varicocelectomy, as we know it also as Palomo, high ligation, highest entry point, or abdominal varicocelectomy. Treatment of couples with unexplained infertility. The first line management is expected management. The second line management is the stimulated intrauterine insemination with either clomiphene or letrozole. How many cycles? Up to 6 cycles. 3 to 6 cycles is something which are given to the patients. Third line management is IVF alone rather than with ICSI, because ICSI does not improve the pregnancy chances, while IVF is more cost effective and equally efficacious as ICSI in patients with unexplained infertility. The same thing in the algorithm form. First line is expected management, second line is stimulated IOI, and third line is IVF. Thank you all for your patient listening. I hope these guidelines which have been launched in 2025 by WHO have been useful to you, and please leave for any comments in case you find any problem in understanding anything. Thank you.